whether it's experimental data, archival data, quantitative, non-quantitative, and apply it to solve really important problems in the world. That's what we want Chicago to be. So that's sort of the elevator pitch. Again, over. All right, let's move right to Matt. And so Matt, many of you may not know, Matt began life as a faculty member at Google. And then a few years later, very early Northwestern economics hired him away with tenure. We were very, very fortunate to get Matt back 3 or 4 years ago. And now he and Dan Edelman oversee our healthcare initiative. Healthcare, of course, is a massive part of the GDP of this country, an area our students want to be involved in, whether it's, in terms of running healthcare organizations or investing in healthcare. So we're very, very happy that Matt and Dan were able to, Matt was able to come back and take over this initiative. There were a whole bunch of projects and other things planned. So maybe, Matt, let me just start by saying, what was the sort of impetus behind the healthcare initiative, and what are you hoping to achieve from it?
Yeah, I think that's a great intro to the school. And I think we're trying to follow the same playbook in the healthcare initiative by trying to be a data platform for healthcare data. That was the vision that Dan Edelman. So he's a professor of operations research. He's been here 25 years or more. He doesn't look it. But when I was recruited back in 2020, I was recruited to be the faculty co-director with Dan for this new healthcare initiative. And so I joined in 2020. It's very weird to start a new job in the I couldn't even get into my old office. I couldn't get any of my old books. Faculty weren't really coming into their offices. But so people probably didn't even know I was back at Booth for like another year. But we started off by trying to make it easier to get access to healthcare data for research, to support faculty research, to support students. That was one of the things we tried to do. And we've been building out our curriculum. So we've been trying to add new healthcare courses. Actually, if any of you have feedback on how we could be expanding our healthcare curriculum, Dan and I are always excited to get feedback from alums about that. We have a couple of healthcare courses already, and we're trying to build that out to have a couple more. Faculty approved a new concentration in healthcare, I guess that was early last year, and it's already one of the most popular concentrations. So we have enough healthcare courses now that we can offer a concentration in healthcare. It's a little strange because, we don't think of ourselves as being discipline based. We wouldn't have a concentration in a particular sector, but I think healthcare is a bit special, and I think it's gotten off to a pretty good start. We have healthcare student groups that are supporting long-term events, and I think we're continuing to grow.
So this book, which all of you are going to get, it's a fantastic book. And so I was going to ask Matt just some questions about that, but start with the first question, right? Matt's a healthcare economist. So one of the first questions is like, why do we need a separate notion of healthcare economics, right? As opposed to, I'm an economist in some other industry. So why is healthcare different? Why do we need separate healthcare?
Yeah, we have agricultural economists. We have Austin Goolsbee, who is my former colleague. Sadly, he's now moved on to bigger, better things. He's the president of Chicago Fed now. So I don't get to see him as much anymore. He would describe himself as a media economist. So I think, economics has general principles, and we teach supply and demand, we teach the importance of incentives, we teach incidence efficiency. All of those concepts, I think, do matter in healthcare, just as they do in other sectors. But there are a couple of things that make healthcare special, and that was one of the motivations for the book. Is like, what are the economic concepts that make thinking about the business of healthcare different than other sectors? So maybe I'll just give one example, because I don't want to tell you about the whole book. But one of the examples that we talk about is just thinking about the perspective of an insurance company. Think about their profit. Their profit is they collect healthcare premiums, and then they have costs which come from claims. At a very high level, that's basically their business model. When they design a health insurance contract, they have to think about who are the consumers that are going to sign up for their insurance, because who signs up determines the cost, and thinking about the cost determines their profit. It matters if you attract healthy people or sick people to your plan. Now, maybe that sounds kind of obvious, but not every business works that way, right? If you're making a television, you don't care who buys the television, right? Your profit is just how much I'm selling the television for minus my cost. In healthcare, and particularly health insurance, who buys the product determines the cost. So the firm cares about the identity, the characteristics, and the cost of who buys it. Economists now call these selection markets, because the selection of consumers who are selecting your product determines your cost, and thus your profit. Health insurance is one example, but there's other examples even outside of healthcare, like credit card companies. If you attract a bunch of people to buy your credit card or to sign up for a credit card who then don't pay their bills, you're not going to have a profitable credit card. It's the same kind of economic logic that we develop in the chapter, in one of the chapters, and we apply it to healthcare. So what does this mean for businesses? Well, imagine you're running a Medicare Advantage plan. I'm not going to get into all the details of Medicare, but Medicare has been partially privatized through a program called Medicare Advantage. Private health insurance companies offer Medicare plans to people when they turn 65 of Medicare. It's a very active part of the healthcare landscape right now, because these plans are essentially competing for consumers. Now, suppose you design a plan that has free gym membership. Okay, if you offer a free gym membership, well, maybe because if people have gym memberships, then they go to the gym and they're healthy, and if they become healthier, then that might lower the costs. But alternatively, offering a gym membership could just attract healthy people, and that could be profitable innovation, because you're essentially like cream skimming. You're trying to select the healthy consumers to pick your plan and not get the unhealthy consumers to pick your plan. So that's just one example of what makes health economics different from the economics of other sectors.
So we think about Chicago as being the home of sort of market economics, free economics, and one of the points you make in this book is that really doesn't work for healthcare, right? Like just like a free, unregulated market may not be the right solution. Maybe you could touch a bit upon that. Like, where does the Chicago model?
Yeah, that's why I should say I teach a health economics class now to the Booth MBA. So I do a full-time and part-time section of that class. And so this is the third time teaching it. There's students from the last 2 years are in the acknowledgements, because I gave draft chapters for the last 2 years and they gave feedback. And so that was great. So I assigned a few chapters of the book to the Booth students. And that's actually the part of the book that gets the most discussion from them, because it quickly gets into politics, really, which is really, how is the government supposed to be involved in the healthcare sector? And one way of thinking about it is thinking about how health insurance markets would work if there was no government involvement at all. One of the ways that the government got involved during the Affordable Care Act, so that was something we call Obamacare, the landmark legislation in 2014 that expanded Medicaid and created health insurance exchanges. It also had one piece that was very politically unpopular, which was the mandate. The mandate was essentially requiring people to purchase insurance under the threat of a penalty that would be enforced in the tax code. So when you file your taxes, for a number of years, you had extra tax forms to make sure you had health insurance, otherwise you would get a penalty. Now we don't have that anymore. So I talk about that a little bit in the book, and the intellectual history here is that many health economists thought that the mandate was important for the economics. It's important to make sure that the market functioned properly, that you have enough of a mix of healthy people and sick people together in that market, so that the insurance companies would be able to cover their costs. And interestingly, what we talk about in my class is that when we got rid of the mandate, some people predicted that it would be very disruptive to the health insurance exchanges, and perhaps surprisingly, they still worked all right, and suggest that I think the health economists, the conceptual tools they have for thinking about why the mandate was so important, might not be right. And you can read the book for more explanations about that. And the way that I started to think about this from a policy perspective is, the mandate, I think, at the end of the day, is not really about the economics. It's really about more of a paternalistic notion that we just feel like people shouldn't have health insurance. And it's okay for the government to be paternalistic from time to time. Maybe we really want people to have health insurance, but it's not really about the economics, because the economics would suggest that if you get rid of the mandate, the market's going to break down, and we just didn't observe that. It's just something that doesn't quite work.
One of the things you point out in the book is that so much about health economics is just not known or well understood. What makes doing research in it or getting findings so hard compared to other fields?
Yeah, I didn't start out doing health economics. I started out when I was a grad student. I went to grad school thinking I would do labor economics. I did labor economics and corporate finance, because before grad school, I worked at Lehman Brothers. I was a mortgage-backed securities desk. 2004, I have all this huge flag. So my timing was good. So I worked there in 2004, 2005. I got very good bonuses. I mean, for like a 24-year-old, it was like infinite amounts of money. And then I went to grad school, and And I thought, well, given all that work experience in finance, I would try to combine more finance and healthcare. I still find, that combination very interesting. But it's just sometimes it happens in life that you just run into somebody and it changes your course. So I started working for Amy Finkelstein, the health economist at MIT, and she became one of my dissertation advisors. And she was the one that basically turned me to healthcare. And her pitch was practical in the sense that her explanation was that health economics relative to other fields in economics was a less mature field, meaning that from a research perspective, there were a lot of open questions. I went to grad school thinking I would study labor markets and study unemployment. And if you had to go into psychoanalyze where that comes from, I grew up in Ohio and there was a lot of unemployment from declining manufacturing. Maybe that's what got me interested. I'm still interested in that. But, coming up with something new to say about unemployment, and research is all about scientific novelty, coming up with a new idea of unemployment is difficult. We've been studying unemployment as long as we've been studying economics. But healthcare, there's just a lot of fundamental things we don't know. And that, I like that practical pitch. It made me feel like, well, I can come up with some ideas that other people would not have thought of. And that's really how my career started, is I felt like I always had more success publishing my healthcare papers compared to my labor papers. Because the bar is maybe not so high. There's just a lot of things we don't know. And it doesn't, and I took advantage of that, frankly. And so to where we are today, when I try to get students interested in healthcare research, what are the challenges? What are the barriers? One challenge is just, there's a lot you have to learn about. The healthcare system is very messy. So before you start doing research, there's a lot of stuff you need to learn, a lot of institutional details that you have to learn. I think make it a higher barrier to entry than maybe other types of economic research. So that's one thing. And the other thing is just it's very hard to get access to the right kinds of healthcare data, because healthcare data is very sensitive. You can download the census data, you can download the current population survey, but you can't easily download healthcare claims or medical records, right? And so one of the things that I think we've been really successful in our healthcare initiative is trying to reduce those barriers by having the staff at booth facilitate getting access to the healthcare data we already have around the University of Chicago. So just as an example, through our initiative, we've been buying lots of de-identified Medicaid and Medicare data. And once you have that data at the university, you can reuse it. But since it's healthcare data, they don't make it easy to do that. There's just a bunch of paperwork. There's IRBs, you have to go through the data agreements. And so we feel like one of the things we're trying to do is make it easy for the faculty and students at booth that want to do healthcare research to get access to the data we already have. It doesn't sound like that should be hard, but we've had to kind of streamline that process thoughtfully in a way that I think has helped make it easy for students to do healthcare research. And we've already had some great successes of students whose dissertations wouldn't have been possible without our healthcare initiative. That's been really great.
And so you mentioned, I guess Alex mentioned at the beginning, you were doing a bunch of work with state governments. I mean, what is that about?
Yeah, I've been for a long time very interested in Medicaid and Medicare. Government spends a tremendous amount of money on this program, if the government's getting its money's worth. And one of the ways that I've tried to make progress in research perspective is try to talk to people that are running Medicaid in different state agencies and try to ask them, well, what are your pain points? What do you think you could be doing better? How can we help you learn about what's working, what's not working? And the thing that I'm most excited about is try to convince them to run randomized evaluations to learn what works. I mean, we do this for figuring out whether a drug works. We do a randomized trial where some people get the drug and some people get the placebo. That's how we learn whether the drug works. If a state's got an incentive program for Medicaid plans and they want to know whether it's working or not, if we can work with them to try to structure that as a randomized evaluation, then you can learn rigorously what works. What companies do. I mean, it's basically an A/B test. But you don't see that a lot in healthcare. And I'm trying to get state governments to do more of that, learn what works with healthcare. That's probably some of the research projects I'm most excited about right now. States that I'm working in so South Carolina has been probably one of the best partners. I don't really know why, but there's a lot of new Chicago faculty that have worked with South Carolina. Our provost, Kate Baker, she's a health economist, and she's worked in South Carolina on multiple randomized evaluations of different programs. And I'm just trying to think back on that.
And are these programs where you're trying to evaluate like actual policies that the state has in place and maybe change them eventually?
Yeah, so I mean, just as and not to get too much into the weeds, but the Medicaid, some of the things Medicaid I'm most excited about is I mentioned Medicare Advantage earlier. So those are the private plans that are offered to people when they turn 65. Most states, what they do in their Medicaid program is they do something similar, which is they allow private insurance companies to offer Medicaid plans. So when you sign up for Medicaid, you choose from one of these plans that are being offered. The state scores those plans, basically gives you report cards about whether these plans are good or not. But those evaluations are not necessarily the best way to evaluate the plan, in part because people don't choose the plan at random. So some of these plans could look like they're good plans just because they're selecting healthy people. It's kind of the same problem that I alluded to before. So how do you distinguish whether this plan is actually having a good impact or whether the plan is just somehow attracting people who just look healthy and would be healthy no matter what plan they're in? That's in treatment versus selection. And so, we presented the state with some tools to try to do that more rigorously, and that's what we're evaluating. This is probably the project I was most excited about, and then the pandemic happened. And the problem with the pandemic is that then all of our data requests become very low priority relative to all the other things the state's dealing with. So in a nutshell, that's why I wrote the book, because I was just waiting to get data. Just needed something to do to fill in time. And my co-author finally wore me down. He'd been asking me to work with this for many, many years. And honestly, I'd rather be writing papers, but just because of the pandemic, it became difficult to get to engage with the government the same way that I was before, and understandably, because there's just a lot of other things that are more important for that.
So one of the things you point out in the book is that people, when they make decisions about healthcare, don't often do it in sort of a rational way. So maybe you could comment on that.
I'm gonna take that question as an opportunity to talk more about behavioral science. I mentioned the behavioral science. I mean, Booth was a real leader here. That's my understanding of the intellectual history, is that no other business school was thinking that they should be investing in the behavioral science group. That we think of business schools as having accounting and marketing, finance and economics, not behavioral science. And Booth started this, and now lots of top business schools are copying it. Behavioral science at Booth, to me, what it means is it's basically a group that combines psychologists and behavioral economists together and try to understand how people actually make decisions, because economists have models for how people make decisions, but those models, sometimes they work okay, but a lot of times they're really lacking. And I think healthcare could learn a lot from engaging more with behavioral science. And that will take you into things like nudges, which of course, my colleague Taylor became famous for. But it's not really just nudges, it's just how do people assess risk? How do you decide whether you want insurance or what kind of insurance you want, how much insurance you need? And that's some of the things I love to talk about in our class, is that there's a lot of consumers that it's just for whatever reason, they seem like they don't think they need insurance. Maybe they think they're invincible or something. But this matters for policy, because states are trying to get people to sign up for insurance, and it's hard to do it. You really have to subsidize hell out of the insurance to get people to sign up for it, because I think a lot of people, either because they misperceive their actual risk, or they just don't think insurance is one of the things that they should be buying. They got other things to worry about. They got other things on their budget. So that's where I think the behavioral science can come in, is just to have more reliable models of decision making to understand how people actually make these trade-offs in healthcare.
So one question always that comes up, right, is do incentives really play a role in healthcare, right? And so when we think about doctors, we're trained to think that this is a noble profession and we're sort of doing it because it's sort of the right thing to do. So what alternative? Do we know anything about whether doctors will always do the right thing? Do incentives matter to the kinds of?
Yeah, we've got some good examples in the book of doctors responding to incentives. I won't go through all of them. You mentioned all these programs. There's one that I guess Alex mentioned it, which he was here to meet our healthcare fellows. Our healthcare fellows are MD, MBA students. This is always going to be a small program, but it's one that I think is going really well right now. So every year we get about 5 to 10 MD, MBA students that are doing their MD at U Chicago while simultaneously doing their MBA. I guess they don't literally do it at the same time. They kind of alternate back and forth, where they do like a couple years in med school, a couple years in MBA. Their med school degree. So these students are great to have in the classroom, because then when you talk about things like how do doctors make decisions, they're going through their med school training, they can talk about what they've heard or they've seen, they've experienced in their rotations. And what I learned from that is that, well, I mean, the doctors are trained in a certain medical ethics that do impact their decision making. So it's not like they're always and only going to be responding to financial incentives, because if those incentives are in conflict with basic medical ethics, then the doctors just aren't going to do it, right? There are certain things that the doctors are not going to do, even if it comes at their own financial expense or the financial expense not. Okay, but there's a bunch of other, like we can describe it maybe more gray areas, where it's not violating the doctor's medical ethics, but there is still some financial incentive, again, for either them or the hospital or both. And then we have examples in the book of where it does look like the doctors are making decisions that seem like they're responding to financial incentives. That could either be when it comes to prescribing drugs or making treatment decisions. I think it's fair to say that doctors will rarely make decisions in a way that's going to actively harm the patient. But if their decision is not going to harm the patient, and this decision might come with some additional financial benefit, then in some cases you can see the doctors responding to those financial benefits. Whether those benefits are, I get paid more for a particular type of treatment, or I get paid more to prescribe a particular drug. Again, if I don't think it's harming the patient, then I might be responding to the financial incentive in some cases. Now, it depends on the doctor. And because some doctors have those financial incentives, other doctors don't. When would the doctors not have those financial incentives? If you're just paid a fixed salary. So actually here in California, we have, as a permanente, doctors are salaried. In the data that I present to the students in my class, the Kaiser doctors seem least susceptible to a lot of these incentives that we're talking about. And it's pretty easy to see why, because they don't have, at the end of the day, the financial incentive to overprescribe, to choose more expensive treatments. They're just paid a fixed salary. And anecdotally, what I think is pretty interesting when I talk to our MD MBAs is that the Kaiser residency seems to be getting increasingly popular over time. I think in part because, and this is speculative, just based on the anecdotes I hear from my students, is that it feels like you're going back to how medicine used to be, where the doctors were making their own decisions based on what they thought was best for the patient without being overly influenced by either financial incentives or just all of the paperwork and hassles and prior authorizations and every other barrier that you put in front of doctors when they're making decisions about what to do, which I think is really interesting. It'd be great to study that more rigorously.
Maybe let me ask you a bigger picture question. I mean, we talked about COVID, and obviously that had a really, people who were in healthcare at the time, it was very, very stressful time for them. Post-COVID, how has healthcare been impacted by that?
Oh, great. Yeah, I'd love to get feedback on this, because it's research that I've been thinking about recently. But the COVID pandemic was an extremely strange recession in many ways. Well, number one, I mean, unemployment spiked. It went up super fast and went down super fast. So that's not usually how recessions work. Recessions, typically, unemployment spikes quickly and comes down slowly. That didn't happen. Okay, but you probably read about that. What I think has been less discussed is it was also extremely unusual in the healthcare sector. So prior to the COVID pandemic, every recession in my life, healthcare was recession-proof. Like we used to talk about healthcare jobs being recession-proof. Every recession in my life prior to the COVID pandemic, if you just graphed the healthcare workforce, it's just going up linearly in percentage terms. It's just steadily, like manufacturing goes down a lot, construction goes down a lot, retail goes down a lot every recession. Healthcare, you just straight line. Even the Great Recession, biggest recession of my lifetime, healthcare still goes up. And then the pandemic completely changed that. Healthcare was actually more negatively affected than almost every other sector. The only sectors that were harder hit were, unsurprisingly, like leisure, hospitality, things that had to get shut down during the pandemic. So the healthcare workforce shrunk by about 10 to 15% in 2020 and recovered quite slowly. So if you just graph the healthcare employment for the last 40 years, it looks like a straight line until the COVID pandemic, and then it drops and it recovers slowly. It recovers more slowly than many other sectors. So if you extrapolated out that growth rate for 40 years, which seems like a reasonable thing to do, because again, healthcare employment's been growing so steadily for so long. And then you look at where healthcare employment is today relative to that linear extrapolation, we're short about 600,000 to 700,000 healthcare workers. And so I think we can call that basically a healthcare worker shortage. You talk to people in healthcare and this resonates with that. It's been hard to bring people back into the healthcare workforce in the aftermath of the pandemic, particularly younger workers and older workers. What I mean by that is particularly workers at the extremes of the age distribution. And what our sort of tentative interpretation of that is that it's becoming difficult to recruit new people into the healthcare workforce. And a lot of people retired early and just decided, I'm done with this, and they have not come back. And what we don't know, because our data is not great, we don't know what those workers are doing instead. So we're working on fielding some new surveys the next couple of months to try to understand that. But if I can call these like missing healthcare workers, they do seem to be disproportionately nurses, technicians, physician assistants. It's not like the non-clinical healthcare workers; they've all come back. And so that's the fact. The fact is we're missing a lot of healthcare workers, and we either need to replace them or we need to come up with some alternative. We need to be able to do what we were doing with fewer healthcare workers. Maybe we need to come up with some new technology to just do less. And the last thing I'll mention is, then this is where you just put on your Chicago economist hat. You see this fact, and there's two immediate explanations: supply and demand. Either the demand for healthcare workers has fallen and recovered slowly, or the supply of workers into healthcare has fallen and recovered slowly. I think we can very easily rule out demand because healthcare job postings continue to surge and are running above almost every other sector. So it's not like firms don't want to hire healthcare workers anymore. They're trying and they're not succeeding. And so that rules out demand and then leads us to supply. Now, why is the supply of healthcare workers been lagging? We have two hypotheses. One is that something about the pandemic just made healthcare work less desirable. I mean, all of you could think about what that could mean. It's burnout, it's just being in the hospital work than it used to be. Another explanation, though, which I think is one worth also considering, is that the labor market recovered quite rapidly, particularly in the low to middle parts of the income distribution. And I think that when you talk to people in healthcare, some of them have this sense that people in healthcare are very mission driven, that they're doing this because there's a bigger purpose. And I think that might be true for some workers, but it might not be true for all healthcare workers. Now, I mean, a lot of healthcare workers that were working in healthcare because it was a job that paid all right. And if there are other jobs that pay even better, then they're not going to hesitate to leave. And I think sort of distinguishing the kind of burnout-based explanation from there's other jobs out there that are better explanation is important, because if we want to try to rebuild the healthcare workforce, we need to know which of those two explanations is relatively more important, because it's going to have different implications for what we should be doing about it. So I would love to get thoughts about how we could be investigating that, or just your own thoughts on which of these explanations resonates more with you. Help us.
Fascinating. So we hear a lot, of course, about the money spent on healthcare and percentage of GDP and those kind of things. So we have one question that came in about how do you see preventative health being covered and funded over time?
Yeah, it's hard. One reason why it's hard is that, think about it from the perspective of an insurance company that's trying to get people to do preventive care. They're only going to care to the extent that this saves money on the back. I mean, unless they're altruistic. They're only going to want to encourage the types of preventive care that are successful enough that it leads to reductions in spending down the line. Okay. Best example of this is flu shots. We talked to a large insurer during the pandemic, made us sign a bunch of NDAs. And even though we had signed these NDAs, they wouldn't tell us anything about how they were getting people to get flu shots. They view this as incredibly valuable intellectual property because they were so convinced in their own data that getting people to get a flu shot, whether because you give them a discount, you give them some free stuff at the pharmacy, you give them, think about like a CVS, like you give them free Gatorade or something, give them a $15 coupon, and all of that and more. And to the extent that it succeeds in getting people to get a flu shot who otherwise wouldn't have gotten a flu shot, pays off for their bottom line, for their book, for their insured book. Because getting a flu shot, you're likely to get a flu. Many people, if they get the flu, there's some chance that there's big downstream health expense. Actually, my youngest daughter got really hit with the flu this year, and ended up taking her to the yard. She was fine, but that cost you Chicago a lot of money. If there was a better flu shot that would have protected her from not getting influenza A, would have saved you Chicago a lot. But she had a flu shot, I should say. It just didn't protect her this time. But I'm saying That's an example of preventive care that the insurers already want to pay. In fact, they want to pay people to get it. They don't just want it to be free. They want the price to be negative in microeconomics speak. So that's just one example. But there's other things. There's other types of preventive care that we think that we should be doing, or we think we should be getting people to be doing. But then when you talk to the insurance company about it, then they kind of have this attitude of like, well, we're not really sure it pays off, so we're not really sure whether we should be encouraged or not. And I kind of think that's where a lot of the debate or the discussion is right now, which is what kinds of preventive care is the kind of preventive care that actually saves money, and what kind of preventive care sounds good, but maybe doesn't save money in the end. And I think that's where the data comes in. You got to be able to test it. Maybe the last thing I'll mention about this is that because of the way the healthcare system works in the United States, many people don't stay with the same insurance company for more than a few years, because if you change jobs, your new job might not be at the same insurance company. And so when we were talking with this large insurer, the way they describe it is like any preventive care that we're thinking about, if it saves money, but those savings accrue like 5 years in the future, doesn't matter to us. That's saving someone else money. And this isn't, if you describe this as like an inefficiency in the healthcare system. Suppose it saved Medicare money. What does a large insurer care about Medicare money? And so that to me is more of a policy question than a business question, which is trying to think creatively about how can we come up with ways of sort of fixing these incentives to get people to nudge people to get the right kind of preventive care that we think does pay off. It just doesn't pay off to the insurer that's the one spending the money getting them to get the preventive care. I don't have any answer to that, but I actually think that there's a lot of interesting things going on here. Maybe I'll just give one example, like the hepatitis C drugs. They're amazing. They cure. They're complete cures. And so, if you do like a cost-benefit analysis globally, even though the drugs are expensive, they save money because you reduce the risk of expensive treatments related to liver disease. You reduce the risk of getting liver transplant, which is very expensive. So somebody should be paying for it. But the person paying for it is probably not the same person that's going to be benefiting financially down the line, because that's Medicaid and Medicare. And that feels like that's just one example of where you have to somehow get people working together to understand that there's going to be certain types of care that probably save a lot of money, but right now the person that's got to pay for it is not going to be the one that gets the savings. It feels like a financial engineering problem. I don't know if I believe in that. In the sense that there should be a way to engineer things such that there can be compensations or transfers so that the savings feed back to the people who put out the money to begin with. But we're pretty far from there, right?
So maybe I'll ask one last question and then open it up. So given that you have some people, let's say the insurance company doesn't want to pay because the benefit is to Medicare, is the evidence that single payer systems are better than what we have in the US?
Yeah, that's like the $1 million question. I've studied health economics for like 18 years, and I feel like I go back and forth. What do I think I've learned? I think I've learned that people should have health insurance, because when people don't have health insurance, they are very likely to accumulate thousands of dollars of unpaid medical bills, and it looks like they forego care that's pretty bad for their health. Now, whether that health insurance should be part of a single payer system, whether it should be rather just subsidized insurance system like the exchanges, I guess I'm still pretty open-minded. I'm not sure what's the best, to be honest. Our healthcare system is easy to criticize because we have pretty bad health outcomes compared to other high-income countries. Life expectancy is lower than virtually every European country, for example. I get a little annoyed when people kind of blame that on the healthcare system. Just to give an example, like I live in Hyde Park. There's great data on like life expectancy by neighborhood. Our life expectancy in Hyde Park, where the University of Chicago is 85, higher than every country. We beat Japan. Like just our neighborhood, we beat Japan. I don't think we live in Hyde Park. Our neighborhood next to Hyde Park, and that might remember it, Englewood, just a couple miles west of my office. Englewood life expectancy is 67. That's lower than Ethiopia, India, Indonesia. Now it's like an 18-year gap. It's just implausible to me that this is primarily the healthcare system. Like if only Englewood residents had access to better doctors, better hospitals, then you close some of that gap. I think you have to take a broader perspective, which is actually how we had to end the book. So, when you submit what I learned, you submit a book proposal, it goes to academic reviewers. They're just like referees on academic papers, and they tell you what they like and don't like. They mostly liked everything, but they said there was one thing missing, which is that we didn't talk about the social determinants of health. And when you think about things like enormous life expectancy differences, I think it's really hard to think seriously about it without thinking about health behaviors and other, likely social determinants of health outcomes. And they really have nothing to do with the healthcare system. So it's kind of a different way of answering the question of just, should we have single payer or not? I'm not sure, but I don't think single payer would do much to improve the health outcomes that are quite bad in this country. I think you need to take a broader perspective about all of the other behaviors and choices that people in America make that lead to particularly bad health outcomes compared to other. And we don't have answers in the book, but we have some examples of where researchers have tried, I think, quite creatively come up with randomized interventions to try different ways of addressing the social determinants of health. And I'm super excited about what we're doing that.
Thank you, Matt. So let me open it up to questions. Yeah, please.
Great. Comments. There's two interesting comments in the line. 2 points. One about if you had hepatitis C medication covered, the benefit accrues really to Medicare, Medicaid, in other words, to the government. And yet, you would see, oh, well, then the government should just pay for it. But of course, what's the factor? Because our government isn't empowered to actually negotiate price. We've created a system of sort of monopolies that where in essence, the price, there is no negotiating power, either often between healthcare companies and insurance companies, or they become these giant markets that sort of outprice each other and just pass on the cost. So I'm curious on something like that. What do you say if the government could act as a rational single payer like in Europe, whether that would work? And because it's sort of social policy of almost we don't want to say anything's right or wrong. And then, so the government almost acts like a disempowered victim in negotiations.
Yeah, well, we're going to start experimenting with this in the case of Medicare, at least. So the government's going to be negotiating, I think, initially pretty aggressively on drug prices for a small number of drugs. So I think we can see how that works. My co-author, Craig Garthwaite, who's at Kellogg, he's out back, so we've worked together on papers for many years. And I think it's fair to describe him as a pretty right-leaning health economist when it comes to health policy, but when it comes to drug pricing, he thinks that there's room to experiment on negotiating drug prices, because the government's spending the money. They should make sure that they're good stewards of taxpayer dollars, and if they can negotiate good prices, there's potential effect on innovation. But Craig, he's more of an expert than I am on drug pricing. His reading of the evidence that those innovation effects are not going to be large enough to overturn what could be a substantial savings to Medicare from negotiating drug prices aggressively. It's just a question of which drugs do you include, how do you think about it. In this specific case of hepatitis, the way that some states have dealt with this is they've been experimenting with what I described in class as like a Netflix pricing model. Netflix, of course, you get a subscription, you get to watch as much as you want. I think Netflix still works that way. So you don't pay for streaming. And so what the states negotiated is we're just going to pay the drug company the fixed fee, and then we get as many prescriptions as we want. And the nice thing about that from an incentive perspective is that now the state has an incentive to actually get as many people on the drug as possible. They now have to go out in the communities, find all the individuals who would benefit from the drug. Sadly, that turns out to be the last mile problem, I guess. Sendel, talking that term. Our college said one day that the last mile problem is just finding the people that could benefit from the drug. It's not always obvious where they are, how to find them, or even to get them to come to the appointment and actually take the drug. But it's a pricing model that I think is kind of interesting, because you're not negotiating per pill, you're just getting a fixed fee, and then I get as many prescriptions as I want, basically. It's still, at the end of the day, though, suffers from the issue that I described, which is that, this is the story that I heard when I started talking to South Carolina, is that, their estimates is that if they treated everybody that they think is out there, it would use up all the Medicaid budget. and there'd be no money left over for anything else. And again, it's the savings though are going to Medicare, not Medicaid. So you need to get Medicaid and Medicare talking to each other. Now that's still both government agencies, but I can tell you from working with multiple government agencies, it's like it's no easier to get Medicaid to talk to Medicare as it is to get like Aetna to talk to Medicare. It might as well be all completely separate organizations. So I think that's kind of the procedural challenge in trying to make these.
We had a question at the back.
Very fascinating. So I have been in the healthcare industry for about 15 years, and recently we set up a fund investing for longevity. And of course, that opens Pandora box, per se. And people say the longer the healthcare process is going to be higher. But my personal view is if you look at all the blue zones get actually lower, more healthier for longer. That's how you get to be a veterinarian. Or you don't get to be something when you're back in the 70s. And so it does raise a lot of the economic questions, not only healthcare, but also social economics.
Yeah,
as well.
that's fascinating.
So how have you looked at that area? And I would love to hear.
Yeah, I was just talking about it there. So the team of economists working on the way they, I think I talked about it, they described it that they're trying to understand the economic value of aging therapy, which would help people live longer. And I like the question because I can put on my labor economics hat. And the way that labor economists think about longevity is that it may also encourage people if they're living longer and in good health longer, they may also be willing to choose to work longer in a way that I think has first order impact on a lot of these like fiscal calculations that you would have in mind. If people live longer and they all retire at the same age, even if they're healthy, that's probably going to be tough for Social Security and Medicare, for example. But if people are living longer and they're productive longer and willing to work longer, then it's not necessarily a bad thing from our public finances. So if people are living longer and we're willing to say, raise the statutory retirement age, I mean, many other high-income countries are doing this. I guess France is the exception. They were in the streets, being on their grills, protesting. I think it was to go from 62 or something to 64. But like, what I think of as the well-run Scandinavian countries have been steadily increasing their statutory retirement age. And if that goes hand in hand with life expectancy gains, then I don't think you need to be worried about the impact on the government budget. And I would just say, put my health economics hat back on. I mean, I think the value of aging therapies and the value of getting people to live longer is incredibly high. I mean, the way that economists think about this, because we love to put a dollar value on everything, is you just put a dollar value on additional life years. Economists call this the value of a statistical life year. I guess all of the people describe it as, they adjust for whether that year is in good health or not. But if you take the dollar value seriously, then increases in life expectancy are incredibly valuable to society. We might be willing to pay quite a bit more to just get an extra 5-10 years of life as long as it's in good health. And I think that suggests, we should be willing to invest a lot in therapy that lets longer. Yeah.
How do you improve people's quality of life? And if you do, does it lower healthcare costs? And specifically, I feel like everybody's looking for the next pill to, whether it's weight loss or ED or whatever it is. I actually live 2 miles away from my office. I walk to work. When I started walking to work during COVID, my heartburn went down, my psoriasis and things like that went down. I feel better. I'm spending less money. I don't see a doctor at all. That's just a personal. But I feel like if you improve people's lives, if they have a better quality of life, if they're not, stuck in a car commuting an hour, if they're not sitting at a desk for 14 hours like many of us do, you actually, and even, drug problems like fentanyl and tweaking out and stuff like that. how do you change the paradigm of people, seeking a pill or seeking a doctor just to improve the life versus improving the life on their own?
Yeah, I mean, I think I'll try to answer it specifically by like thinking about some examples of research I think in Chicago. Some of the research that we're doing work on workplace wellness programs. So like workplace wellness is trying to get employees to live healthier lifestyles by encouraging them to exercise, encouraging them to walk, encouraging them to bike. The evidence is not great. Like those programs just don't seem to really do anything. So I think we need to try something else. But I guess I agree with you that it was worth trying those programs because one way to reduce healthcare costs is actually reducing the risk of large out-of-pocket medical expenses by just making people healthier, by just making them live healthier lifestyle. I just don't think we have great evidence on what's the best way to do that. People have been trying, Katie Milkman, who was here at Booth earlier this week, she did this huge mega study with Angela Duckworth on trying to get people to exercise. Tens of thousands of participants, multiple randomized treatments, and they didn't learn nothing really worked very well. It's hard to get people to exercise. Like people buy gym memberships and don't go to the gym, which means people are paying not to go to the gym. That's a behavioral science problem, really. So I think it's important, but I just don't think we have great, we don't have a lot of successes that we can point to. Like this is really something that helps people live healthier lifestyles. I think it would be great to just keep experimenting.
Well, you talk about France or Europe having a higher lifespan, and you see people walking to work, you see people biking to work with a baguette underneath their arm and stuff. It's they're outdoors more. They're enjoying life more. I don't know. Maybe it's anecdotal, but
well, I mean, people here are healthier than people in the Midwest, and I don't know if that's because they're outdoors more. I don't know if it's because they're walking around more. That's the thing. I guess that's the question of causality. Like I think it seems totally plausible to me that this is about being outdoors and lifestyle factors and things like that. That seems totally plausible. But another explanation that I've heard recently that I think seems quite intriguing is just loneliness, right? That could potentially matter a lot. When you look, I mean, this is heresy for social scientists, but when you look at the people who live a long time, which is of course selecting on the outcome, it's like asking well, look at all the billionaires they dropped out of college, right? Zuckerberg, Bill Gates, why did I graduate college? That's not a logical way of thinking about it. But setting that aside, if you look at the people that live a long time and you just do a statistical exercise of how are they unusual compared to everybody else, one of the things that really jumps out is that they're very unlikely to say that they're lonely. And so that raises, it's a statistical correlation. I don't want to claim that this is causal, but it raises the possibility that maybe a factor we've been overlooking is social connectedness. And I'm quite willing to believe that the United States is also not great on this compared to other kind of countries. But that's the thing, is we don't know, is it loneliness, is it walking, is it exercise? I think it could be some combination, but I don't know the relative importance. And because I don't know that, I don't know what we should be targeting.
One more question.
And first, welcome Madhav and Mike today here. So my question is, how do you see technology helping the economics of the healthcare sector in future?
My next week's lecture on Monday. And we put it in the book, so it's so there's no chapter in the book I can point you to. But next week's lecture is on technology. I talk about machine learning, and I have a little bit on AI. So some of the examples that seem on the horizon is we already have technology in radiology where the machines do at least as well as doctors. The rollout's been slow. Why is the rollout slow? Because doing anything, I mean, it's sort of like getting faculty to vote on a new degree program. Getting a bunch of people on healthcare to adopt the new technology is very slow, but I think it's inevitable. I think it's inevitable because it's cost effective and more accurate. There's other examples I've been thinking about where the technology can actually complement the human decision making. So one of the examples actually comes from a paper by Sandra Monet, our colleague, was using machine learning models to actually predict whether someone's actually having a heart attack or not based on their symptoms. And this is important because, if you don't think it's a heart attack, you shouldn't be doing something like catheterization. Doctors, there's a decent number of catheterizations where the machine can say with a high degree of certainty, this is not a heart attack. And if the machine can say that and the doctor can be convinced to believe it, you just shouldn't do the catheterization. You should just watch him for a while, send him home. I mean, many is like 40% of the catheterization at both ways. Now, if the machine can be designed in a way that the doctor can understand what it's saying and believe what it's saying and use it to inform their decision making, it can help them make better treatment decisions. Because if they're thinking that they're going to catheterize somebody and the machine said, I'm like 99.6% sure it's not a heart attack, then the doctor might pause and say it's not worth it. That both saves money, reduces the risk of complications, and lets them move on to other patients that need their treatment more. So that's an example of where the machine not substituting for the doctor. First of all, the machine can't do the catheterization right now anyway. It's just giving a prediction about whether this is someone who should be treated or not. One of the really interesting things about Sendell's study is that when you look at where the machine and the doctor are disagreeing, the machine just puts much less weight on the patient saying they had chest pain. Doctors, just think about this as a coefficient and a statistical. Doctors put much more weight on that symptom than the machine. And the doctors really should just be looking for other indications of a heart attack besides chest pain. And so I think that's a really cool example of where technology could really improve medical decision making. And I think that there's just lots of other examples like that of where think about it as like a co-pilot. I mean, that's how software engineers deal with these chatbots these days. It's just someone by your side. The co-pilots explain to you what this function does. Imagine a co-pilot saying, I really don't think the person died of a heart attack. Don't catheterize it. I think that's a pretty exciting opportunity.
Okay, thank you. Thank you very much, Matt.
Can you hear me? Yeah. Fascinating conversation. I'm going to just take a couple of minutes as the closing remark for the session. Before I say that, I do want to highlight a couple of things. It's always so refreshing to hear Dean Rajan. We all see a lot of faculty members, leaders. The qualities that I have captured personally about Dean Rajan are his ability to bring energy, clarity, and prioritization to whatever he has been doing. And I have had the fortune to listen to him in person and just on other things remotely. I mean, you heard all those innovation areas. It requires a lot of clarity about the future, the school, the decision making. So big round of applause for Dean Rajan. Not any other corporate, it's not easy to energize the team on the ground, right? Because we're talking about energizing university members, the faculty, and obviously prioritization, right? How do you launch these many number of programs while keeping that funding momentum going, students? So I personally feel so proud that we have someone like Rajan with us. So thank you, Dean, for all of that. And with Professor Matt also, the level of authenticity and originality that you brought today, I know personally not with you before, but I'm so glad that we have someone like you, and I'm thrilled to be here. With that said, that's what the closing remarks. I'll mention three things. There are three G's that I want to talk about. One is gratitude, second is growth, and third is giving back. And I'll try to summarize it very quickly in just a time. First, I feel high level of gratitude for everybody here in this room, all the way from our faculty and dean to everybody from the school team, Michelle, Trishta, whoever I have met and have not met. Can you please have a big round of applause for them? Covering so many different regions, such a big, like 55,000 plus alumni, you mentioned with all other things, and it requires a lot of things. The knowledge that we get out of these is phenomenal. So my gratitude, and on behalf of everyone, the gratitude to you all. Second thing, now, one of the ways I could see most of the people who graduate and move on in their life professional careers, they grow faster than, again, I don't have the statistical data and stated, it's just anecdotal data and what I observed, is by engaging more with the school, with alumni. It's just natural when you just think back, right? We're talking, you are being the part of this environment, learning what's new, what's coming. So I would invite everybody here. Let's get more engaged. Engagement doesn't have to be only, organizing something. You can get engaged by many ways. And it's good for the individual growth as well as the community. We are only as good as our community is. And third is giving back. I tend to end my closing remarks always with giving back courage to everybody. And I do want to highlight, giving back is not only financial aspect of it, right? The number one thing we all can give back to school, to our community is to attend, right? Keep good alumni school in your mind, right? Share ideas, reach out to somebody. We have people who are going to be signing up for the school, who are applying for the school. We have people who are going through the school. We have someone like Matt Bunkin who's went to the undergrad school. There's so many things we can bring to the team. So with that said, I do want to end the remarks by saying thanks so much for coming. You came from different parts of the Bay Area. Thanks again to Dean and the team and the faculty for organizing this. And please enjoy the rest of the evening. Thank you.